carry on with our SCA crash knowledge updates. So let's look at emergency contraception decision making algorithm. It's from the Faculty of Sexual and Reproductive Health. So you need to, of course, there are different options: copper IUD versus oral emergency contraception, and then deciding whether a patient needs emergency contraception. You want to know if your regular contraception, if yes. And the question is, has she missed her pill or not? If she's not on regular contraception, then when did she have unprotected sexual intercourse? Is she currently within 5 days of her since her last unprotected sexual one within 120 hours? If yes, then obviously you can be considering all options. If it's within 72 hours, then the best option will be levonorgestrel. Well, not really like the best. IUD is always the most effective anyway. So you can consider copper IUD or your lipostal acetate, LR1, or your levonorgestrel. If it's beyond 72 hours since our last protocol session, especially if it's beyond 96 hours within 4 days, you're thinking about more of the like only crystal acetate or your copper IUD. I asking just not just whether she had unprotected sexual intercourse, unprotected sexual intercourse within 5 days. It was within 5 days of her predicted ovulation. So let's have a look at this algorithm here. So currently within 120 CS, additional unprotected sexual intercourse this cycle. So if she had another unprotected sexual intercourse within this cycle, if it's yes, if she currently 5 days or less after the earliest likely date of ovulation. If yes, you offer a copper IUD. If not acceptable, then oral emergency contraception and suitable ongoing contraception. It's difficult to apply this algorithm when you're having a conversation with the patient, so you just need to understand it broadly. Has she had unprotected sexual intercourse? Yes. When was it? When was her last menstrual period? When was her estimated ovulation? Predicted ovulation dates? Was it within 5 days of her estimated or predicted ovulation date? If yes, get the point, then she's at higher risk of pregnancy. I feel like, then you decide on whether you can safely prescribe levonorgestrel, um, emergency contraception, or LR1 on top of IUD. Copper IUD is the most effective, but not all patients will want an invasive procedure like insertion of a copper IUD. So you need to explain all of that to her. Very important thing is explain the risk of ectopic pregnancy. If she becomes pregnant, then restarting that's place of restarting. Let's look at this one. Like someone wants to just show something I want to actually revise. Alright, so if only start accepted emergency pregnancy is given, you start contraception, you resume, or you start, if you want to start and then no contraception, you start contraception after 5 days. And the reason is progesterone, for instance, if you're starting a pulp policy, you see progesterone content of that can reduce the efficacy of the liquid acetates, thereby increasing her chances of getting pregnant, which is not what she wants. So we consider copper IUD if all unprotected sexual intercourse within 120 hours, or if currently within 5 days after likely ovulation. If ulipristal acetate is not suitable, consider levonorgestrel emergency contraception plus immediate quick start of other forms of contraception. Then there's some things to consider in terms of prescribing levonorgestrel contraception. So consider double dose, which is 3 milligram of levonorgestrel if the patient's BMI is greater than 26. Remember, normal BMI is at 18 to 25, 34.9, is but now I think BMI greater than 26. or weight greater than 70, or if the patient is taking an enzyme-inducing medication. So if you're thinking of three, normally level temperature is 1.5 milligram. If she vomits, she's sick within 3 hours of taking it, she should take another one. Polycrystalline could be less effective if a woman is taking an enzyme inducer. If a woman has recently taken a progestogen, like a POP, or one progestogen within a COC, polycrystalline is not recommended for a woman who has severe asthma managed with oral glucocorticoids. It's worth knowing that again because they can throw in this kind of confounders or factors within the SC exam. Patient could be asthmatic as well. So you need to be safe here. What is you do using the polycrystalline? Again, look at this point. We consider copper IUD if all unprotected sessions was happen within 120 hours, or if currently within 5 days after likely ovulation. If currently within 5 days after likely ovulation. Now, these are the methods of emergency contraception in the UK. Copper IUD, penetrating contraceptive device. IUD remains until pregnancy has been excluded, e.g., onset of next menstrual period, or can be kept for ongoing contraception. Indications for using IUD. So if the unprotected sexual intercourse happens within 5 days, where you see within 5 days after the earliest estimated ovulation. Like gestural emergency contraception. So we just again normal dose, so usual dose 1.5 milligram as a single dose. License for use within 7 hours after unprotected sexual intercourse or contraceptive failure. Polycrystal acetate, the progesterone receptor modulator. The progesterone receptor modulator. And in my usual dose is 30 milligram single dose. License for use within 120 hours after unprotected sexual intercourse for point of contraceptive failure. For instance, from the point of missed dose as contraceptive failure. Double dose 3 milligram, the major stress recommended for moms taking an enzyme inducing medication on a double dose 3 milligram should be considered if BMI is more than 26 or body weight of 170 kilogram. Importance, those are important information, but should be considered really. Now, for cow milk protein allergy, it's fairly common. Not something that is more common is actually indigestion. Gastroesophageal reflux in babies much more common than actual cow milk protein allergy. But it's difficult to differentiate the two. So let's look at this cow milk protein allergy algorithm. For cow milk protein allergy algorithm, the child presents healthcare professional assess symptoms and take an allergy focused clinical history. With a suspected non-IgE, so they can have IgE mediated or non-IgE mediated cow milk protein allergy. Usually the IgE mediated is usually more severe, the one that can actually lead to anaphylaxis in severe conditions. With the non-IgE mediated cow milk protein allergy, you have to check the baby's weight, advise milk exclusion. If breastfeeding continues, maternal milk exclusion is indicated. Recommend cow milk substitutes. Provide patient information from allergy care. So essentially exclude cow milk from the baby's diet, from the mom's diet as well. If the allergy continues, then you need to re-challenge. Then of course, if the child improves, symptoms improve, you have to re-challenge with cow's milk after 4 to 6 weeks. If the symptoms return, initially is confirmatory that the child very likely has a cow milk allergy. If symptoms recur confirmed diagnosis, continuous on diet, review by health visitor, review slash rechallenge every 6 months. The symptoms not recall, keep milk in diet. At this point, I say consider referrals allergically if continuing concerns. You could now think, okay, maybe to actually further buttress my suspicion of my diagnosis, I need to do an allergy testing, immunological, allergy testing to confirm that there's an actual, confirm the allergy. I'll make both. The reason I like this algorithm is that's actually the one that is more likely practical or feasible in the exam. Because remember, the exam, this one is too crowded. One looks too crowded. So the exam is just a 12-minute exam. And it's not just you, the doctor will be talking. It's an interaction between you and the patient or the relative, and they ask you questions, and you have to be checking their understanding. So this one is more practical, to be honest. Now, if you think there's a suspected IgE mediated comic, but how will you even know if it's suspected IgE? Usually symptoms feel more severe. There might be respiratory symptoms, might wheeze, severe rash, eczema, um, you know, mm, yeah, so the wheeze, it could be some facial swelling and things like that. IgE mediated. I think there's some things written somewhere. Yep. IgE mediated. So there could be pruritus, acute pruritus, erythema, urticaria, angioedema, atopic dermatitis, vomiting, diarrhea, abdominal colic, yeah, acute rhinitis, runny nose, conjunctivitis, because hay fever, right, like allergic conjunctivitis kind of symptoms, hay fever, allergic rhinitis, as one of those things in IgE mediated. So if you suspect IgE mediated, you have to check the weight. Then because IgE is usually more severe, you would want to do a Calmic specific IgE blood test, so allergy testing, advice for milk exclusion for the baby. If breastfeeding continues, the maternal milk exclusion is indicated. Recommend cow's milk substitutes. Might be extensively hydrolyzed formulas, and often the amino acid formulas, if they extensively hydrolyzed are not helping. Provide patient information from Allergy UK websites. Blood test for specific IgE allergy. If it's positive IgE, and refer to allergy clinic. Sometimes, depending on how old this child is, you might not be confident in collecting the blood sample from a GP. So you might actually be referring to the allergy clinic or the PEDS, for them to do the blood sample. So the IgE is negative, then we challenge with cow's milk after 4 to 6 weeks. The symptoms we call avoid milk and refer to allergic milk. Symptoms now we call keep milk in diet. So this is why. So this is more likely feasible in terms of how you're going to apply the decision making in the SC. Let's look at this one. Let's look at chronic protein allergy. Obviously, there's severe IgE mediated chronic protein allergy, severe having angioedema, anaphylaxis kind of reaction, immediate reaction with severe respiratory and cardiovascular signs and symptoms, which is rarely a severe cardiovascular emergency treatment to admit, send A&E immediately, ambulance if it's that severe, it's an anaphylactic reaction, you need to be giving adrenaline, calling your ambulance for immediate transfer to A&E, speaking with PEDS, the child is being transferred, so never really seen that, but it's possible. let's look at something here. So severe non-IG mediated allergy, mostly 2 to 27 hours after injection of cow milk. So IG is usually more acute, mostly within minutes. For IG is usually mostly within minutes, maybe up to 2 hours. If it's beyond 2 hours, you're thinking more of a non-IgA. 2 to 7 hours non-IgA. I have diarrhea, vomiting, abdominal pain, full refusal. But usually we don't have those allergic rhinitis, allergic conjunctivitis, shortness of breath, wheeze, and some of those things will not be there. Respiratory symptoms will not be there. Respiratory and conjunctivitis. They can have rash and diarrhea in both of them. Yeah, dermatitis in both IG and non-IG. So for this severe non-IG, they said cow's milk free diet, exclusively breastfeeding mother. If the mother is asymptomatic, trial exclusion of all cows from the mother's diet. But then, of course, you have to advise the mom to take calcium and vitamin D so she doesn't become deficient of calcium and vitamin D. If your mother is formula fed, then obviously if the baby is formula fed, you have to remove cow milk protein, but because the baby is not breastfeeding, the mom can carry on having her own cow's milk. If mother is unable to revert to fully breastfeeding, trial of replacement of cow's milk formula. If the child is formula feeding, there's an option of going back to breastfeeding. That's an option if she wants to breastfeed. Otherwise, she might need to use the extensively hydrolyzed formulas or amino acid formula. If infants is asymptomatic on breastfeeding alone, do not exclude cow's milk from maternal diet. Ensure urgent referral to local pediatric services, urgent dietary referral. That's of course for severe non-IgE. It's a mild to moderate non-IgE cow's milk free diet, exclusive trial of exclusion of all cow milk from mother's diet, but then she needs to take calcium and vitamin D. The baby is formula fed, so it's very important to find out if the baby is being breastfed or formula fed. The baby is being breastfed and is having this kind of symptoms, exclusively being breastfed, and tells you that very likely the cow's milk is coming from the mother's diet. You get the point. And it's very unlikely to have cow milk protein allergy. Well, it's possible if an exclusively breastfed baby. More common with formula fed or mixed feeding, where you are breastfeeding and formula feeding. So if formula fed or mixed feeding, if mother is unable to revert to fully breastfeeding, so you have to ask her if she's tell her the options. One, she can go back to breastfeeding alone, or she would carry on with formula feeding, but it has to be a formula feed that doesn't contain cow's milk. So extensively hydrolyzed formulas or the amino acid formulas could be tried. And of course, if it's not a severe reaction, you can always try reintroducing cow's milk within 4 to 6 weeks. Which I then use cow's milk after 4 to 6 weeks. So that's something that can be done. Bedwetting is quite a common pediatric complaint actually. Enuresis, nocturnal enuresis. Children and young people experiencing recurrence of bedwetting. So you can consider an alarm treatment again if a child or young person who was previously dry, so secondary enuresis will be dry, with an alarm and started regularly bedwetting again. Offer combination treatment with an alarm enuresis alarm and desmopressin to children and young people who have more than one recurrence of bedwetting, following successful treatment with an alarm. Consider using repeated courses of desmopressin for children and young people with bedwetting that have responded to testosterone treatment or who experience repeated recurrences. Withdraw desmopressin treatment at regular intervals for 1 week every 3 months. Every 3 months, you might need to broadly desmopressin for 1 week to see to check if there are dry nights. Gradually withdraw desmopressin rather than suddenly stopping it. If a child or young person has had a recurrence of bedwetting following response to previous desmopressin treatment courses, consider alarm treatment as an alternative to continuing medication treatment for children and young people who have recurrences of bedwetting. If an alarm is now considered appropriate, so before you even you need to let's see as a GP, going as a GP, you won't be jumping into despocacy. You're talking about how the reward system, finding out how the child is, the child has had dry nights, if they are potty trained during the day, toilet trained during the day. Um, the child, how the child relieves any constipation, the wee, the smell strong, the child cry when we and on the parents' concerns, expectations, what they're hoping for you doing to help today, and all of that. And extensive management options, reward system, encouraging the child to really have a pee or a wee into their bladder before going to bed, a bedtime before going to bed, and things like that. But they should not be restricting food, or the child can do more of their food during the daytime and less at night. But the child should carry on being drinking and not to the bladder can be, and then they can always try the university's alarm as well. And in addition to the reward system, explain what the alarm, how the alarm works. It's not the child, that the child's pants underwear that's unit, and the alarm is triggered, or the sensor is triggered, and the alarm goes off with the channel inverter, and the child's brain is now wired to, you know, sense when the bladder is full. It's like creating that, connection between the brain, a coordination between the brain and the bladder. So children under 5 years with bedwetting, children are generally expected to be dry at night by a developmental age of 5 years. And historically, it has been common practice not to offer advice to families of children who are younger than 5 years. So historically, this section provides recommendations specific to the under 5 age group, indicating situations where healthcare professionals can often use advice and interventions. Reassure parents or carers that many children under 5 years, especially that, for example, approximately 1 in 5 children, 4.5 years wet the bed, at least once a week. Ask whether toilet training has been attempted, and if not, ask the reason for this and offer support and advice. If there are no reasons why toilet training should be attempted, advise parents or carers to toilet train their child. Suggest a trial of at least 2 nights in a row without nappies or pull-ups for a child with bedwetting who is under 5 years and has been toilet trained by a day for longer than 6 months. Offer advice on alternative bed protection to parents, like using Macintoshes. Consider a longer trial in children who are older who achieve a reduction in violence. If family circumstances allow the trial, okay, advise the parents or carers of a child under 5 years with bedwetting that if the child wakes at night, they should take him or her to the toilet, but they shouldn't be the ones to wake the child to go to the toilet. The child wants to wake and encourage them to actually use the toilet before going back to bed. Consider further assessment and investigation to exclude a specific medical problem for children of what to use. Who these products awareness of toilet needs and showing appropriate toileting behavior struggling to know when themselves. Assess children under 5 years will be bedwetting for constipation. In line with constipation in children and young people, as undiagnosed chronic constipation, a common cause of wetting and silence is also checking about the people who has constipation, who is having difficulty with pulling, straining, or things like that. Precious puberty, but it's possible though. And the mom can come and say she's worried, she's thinking the child will have precocious puberty. Something that can actually happen. I wouldn't be surprised if it's something that could actually come out in some precocious puberty. So the mature sexual development, the history, hospital examinations confirm the early breast development or adrenarche, pubic hair, talaki breast development of menses, but it's usually the breast development and adrenarche, the pubic hair. So there's telaki, menarche, well, there's menarche as well, early menses. Assess both growth velocity and bone age. There's rapid growth rates and advanced bone age. Thinking of hormonal FSH, LH, GnRH. Essentially, you want to find out, I think you're thinking, would it be central precocious puberty or peripheral precocious puberty? Central means maybe excess FSH, LH, or excess GnRH from the hypothalamus, or FSH from the pituitary gland. So, wondering, you want to just find out, or is it something to do with the adrenal glands, like a peripheral precocious puberty? So, we're wondering, should you be doing an MRI of the brain to look at the pituitary hypothalamus, or should you be doing a scan of the pelvic ultrasound of the abdomen to look at the adrenal glands? Should you be doing some hormonal levels as well? Thinking of congenital adrenal hyperplasia, thinking of adrenal tumors, you know what I mean? So it's difficult. So it's okay, you're going to do some blood tests, you will also refer. Bottom line is you need to be referring to the pediatricians for further assessments. And do some of these investigations to find out if it's essentially not peripheral precocious puberty was causing it, really be worried. If it's a male child, precocious puberty, female, is male ultrasound of the gonads, so testicular ultrasound of adrenals and testicles, is female pelvic ultrasound and adrenals, abdomen. Congenital adrenal hyperplasia, imaging is not necessary for the blood tests. That's peripheral perception with not word. Brain man, to image all patients, so MRI brain. Because a normal MRI scan that you were thinking idiopathic central precocious puberty. How you establish that it's a central precocious puberty is from raised FSH and LH. If there's a low FSH LH, then say peripheral precocious puberty. So that's to the LH FSH levels, so maybe in GnR, gonadotropin release one levels. Now for central precocious puberty for female, if any or all of the following are present less than 3 years old, rapid rate of progression or inappropriate sequence of development of secondary sexual characteristics. Neurological signs and symptoms, Indian central and other. If 3 years and older, normal sequence of development of sexual no neurological signs, imaging not necessary, idiopathic. Why? In fact, there are no neurological signs. Does it completely rule out the fact that it could still be a central child is 3 years older? A child is 3 years older. If a 4-year-old child is having, adrenarche or telarche or menarche, you should be worried. So you probably want to find out. I will probably still, I just prefer to kids anyway. I'm imagining kids might, of course, do those blood tests, FSH, LH, GnRH, depending on finding the society this child needs. MRI scan of the brain or not. It's worth knowing that they're central and precocious, left peripheral. It's going to be something to come from the ovaries or the adrenals or something to come from, from the pituitary hypothalamus, the brain. That's the most important thing to be aware of. And it's also a congenital adrenal hyperplasia, which is also an adrenal problem. That's peripheral. It's just good to be aware of all those things. Peripheral artery disease, quite long, not too long. Maybe we should just look at it. And We'll end at peripheral arterial disease, patient having intermittent claudication. Quite a common, SCA, CSA case. How should I manage the patient intermittent claudication? If available, offer a supervised exercise program. So created exercise program, supervised, created exercise program for all people in intermittent claudication. This may involve 2 hours of supervised exercise a week for the 3 months or 3 month period. I encourage you to exercise to the point of maximal pain. Take great exercise, so maximal pain and then take a rest. When the pain eases, then walk. Exercise again to the point of maximal pain. Rest again. Over time, exercise tolerance will be improving. If supervised exercise is not available, consider suggesting unsupervised exercise using clinical judgment and taking into account the person's motivation and competencies. For example, advanced exercise for approximately 30 minutes, 3 to 5 times per week, walking until the onset of symptoms, then resting to recover. Refer for consideration of angioplasty or bypass surgery when advice on the benefits of modifying risk factors has been reinforced. And the supervised exercise program has not led to satisfactory improvement in symptoms. Consider prescribing naftalin oxalate. If supervised exercise has not led to satisfactory improvement and the person prefers to not be referred for consensual angioplasty or bypass surgery. So this definitely sounds like something like a peripheral artery arterial dilator, similar to pentoxifilin. The review progress after 3 to 6 months and discontinue naftalin oxalate if there has been no symptomatic benefit. For people with peripheral artery disease, or whether rating advice about the condition, advice on driving. So if they're having pain while driving, anyone checking their driving safety, asking yourself, should we actually continue driving? Should we actually be driving? Still on peripheral artery disease, how can I manage cardiovascular risk in these patients? Assess for previously undiagnosed cardiovascular conditions and risk factors. Manage appropriately. For more information about managing cardiovascular risk to this topic, all people with peripheral artery disease, information, advice, support, and treatment guiding the secondary prevention of cardiovascular disease. But the peripheral artery disease is already a problem, it's already a cardiovascular risk. They were thinking of with secondary prevention because smoking cessation, weight loss, alcohol, cutting down alcohol to less than 14 minutes per week. Because you want to start them on aspirin or clopidogrel and statin. So lipid modification and statin therapy, prevention, diagnosis, and management of diabetes, antiplatelet therapy, aspirin or clopidogrel, prevention, diagnosis, and treatment of high blood pressure, prevention, diagnosis, and management of diabetic. So these are things we need to be thinking about. Thanks for actual disease. Next, we'll be doing continuing from diabetic review. Cheers.